This lecture focuses on the pulmonary circulation as a unique vascular bed that is structurally and functionally distinct from the systemic circulation. As future physicians, it's critical to understand that pulmonary vessels are optimized for gas exchange rather than pressure generation. We'll connect vascular structure, pressures, flow distribution, and physiologic regulation to clinical phenomena like hypoxemia, pulmonary hypertension, VQ mismatch, and exercise adaptation. Pulmonary circulation is driven by the right side of the heart, specifically the right ventricle, which generates much lower pressures than the left. The pulmonary arteries branch in a tree-like fashion, closely following the bronchial architecture to maximize surface area for exchange. Importantly, about 10% of total blood volume resides in the lungs, making them a dynamic blood reservoir, not as much as the venous system, but still pretty significant. At any given moment, the volume of blood in the pulmonary circulation is approximately equal to the volume in the right heart, which has implications for preload and rapid shifts during exercise or hemorrhage. Pulmonary circulation is a low pressure, high flow, low resistance system. Despite receiving the entire cardiac output, resistance remains low due to thin vessel walls and minimal smooth muscle presence. These vessels are highly compliant, allowing them to accommodate large changes in flow without major increases in pressure. The capillaries form a dense sheet-like network surrounding alveoli, maximizing diffusion capacity while minimizing diffusion distance, a key for efficient gas exchange. Pulmonary arterial pressures are dramatically lower than systemic pressures. During systole, pulmonary artery pressure averages around 22 millimeters of mercury, and during diastole, about 8 millimeters of mercury, with a mean pressure at 15 millimeters of mercury. And this is kind of showing these pressure changes here on this slide. Pulmonary capillary pressure, on the other hand, is even lower, roughly 7 millimeters of mercury, as seen in this central component, which is essential to prevent alveolar flooding. Despite a flow of approximately 5 liters per minute, that's cardiac output, pulmonary vascular resistance is about 1/7 of systemic resistance, highlighting how vessel structure governs the hemodynamics. Unlike the systemic circulation, increases in pulmonary arterial pressure actually decrease pulmonary vascular resistance. This counterintuitive relationship is explained by capillary recruitment, seen here. Previously, under perfused capillaries, so capillaries that aren't receiving as much blood, will open, and capillary distension, where vessels widen in response to flow. Okay, so these two components, capillary recruitment, which is previously underperfused capillaries, open, and capillary distension, where vessels will widen in response to blood flow. These two pieces help explain this kind of counterintuitive relationship. These mechanisms increase surface area, so both of them, and slow blood velocity down, which ensures time for gas exchange to occur, even with this high flow state, such as even in exercise. Pulmonary capillary fluid balance is governed by Starling forces. Outward forces include pulmonary capillary hydrostatic pressure, pushing out, interstitial oncotic pressure, pulling out, negative interstitial pressure. And this all sums to about 29 millimeters of mercury. Inward forces include our plasma oncotic pressure, which is about 28 millimeters of mercury, allowing for a net filtration pressure of 1 millimeter of mercury outward. This delicate balance allows for minimal fluid movement, which is efficiently removed by our lymphatic system, and that keeps our alveoli dry under normal conditions. We don't want our alveoli wet because the more water in our alveoli, the increased surface tension from those hydrogen bonds, and the more likely we'd see alveoli collapse, seen in atelectasis. So what are these Starling forces? Here we kind of formalize the equation. The outward forces equal capillary pressure plus interstitial oncotic pressure minus interstitial hydrostatic pressure, seen here. Even a small disruption, such as increased capillary pressure in left-sided heart failure or decreased oncotic pressure in hypoalbuminemia, can overwhelm lymphatic clearance and lead to pulmonary edema. This is why pulmonary edema can develop rapidly compared to peripheral edema. We'll stop here. When we come back, we're going to look further at the functions of pulmonary circulation.